Well, thank you, everyone. Gosh, this is always such an honor to be here with you all. My name is DJ Wilson. I'm part of the team that hosts this conference every year and which puts out the content on our website, stateofreform.com, and puts out 5 things we're watching, and the web videos, and the small run book publishing, and all the other things that we do to try to facilitate this conversation that we're having today, and which we try to facilitate the other 364 days of the year. So I always look forward to being on this stage. We have a little bit of a microcosm of this conference the night before our events in the form of a dinner, where we get our sponsors and some of our special guests together, and we break bread, and we talk politics. What could go wrong, right? Talk politics, talk healthcare, add a little bit of wine. And it was fantastic, because last night at 2.5 hours into the dinner, I finally was like, it's okay. There's 16, 17 of you. You don't have to stay here. You can leave. And at 3.5 hours, 3 hours and 25 minutes, they finally started leaving. So, Dave Underriner, CEO of Providence, and Jeff Heatherington, CEO of FamilyCare, they're going to be up on the stage here in a minute last night, but they were having the same conversation last night over dinner that you'll hear just momentarily. And it was just really an honor to see them hashing it out. And Monica Webby was there last night, and she was in the mix and fighting with folks and offering her opinion, and it was just really cool. So it's cool to be there, it's cool to be up here, and I just appreciate all of you joining us. So this is our 4th year now in Portland. I'm not a math major, but I think it's our 4th year, and we now have our largest set of registrants. So we're at that place, if you look around with a number of tables that we have, where we might have to start taking out the next room or figure out how we maybe change our screens around a little bit. So it's kind of nice to watch this grow, because it really only grows organically. We, as you know, we have a relatively low price point to charge attendees. We really only can make this because of sponsor support. So we don't do a lot of direct mail. We don't do a lot of advertising. We really sort of rely on the kindness of others to help spread word of mouth. And so we have almost 350 people here with us registered. And we have a natural bell curve. We have, the most people attend at lunch. So it'll be a little crowded at lunch. So make sure you get your seat early, and by the end of the day, people are kind of spent, and so some of them start sneaking out, and we'll have that, of course, here today. And really excited, and of course, this isn't the only thing we do. We have this event. We also have 5 other events that we host, because we think that while national healthcare news is important, healthcare happens locally, and it happens within a market. And so the conversation that happens in Portland is different than what happens in Anchorage or Washington, D.C. or Los Angeles. But we have 6 conferences now on the calendar. In fact, as many of you recall, this conference was supposed to be later in September, I think, 28th. And the legislature went ahead and scheduled their legislative committee days without asking us. And so we thought, and then they scheduled it right when our conference was supposed to be. And so we thought, well, if you're going to have a policy conference and no legislators show up, that's not much of a conference. So we moved our date, and when we called the Hilton here and said, hey, when else do you have available? And they said, well, we have January 6th and we have September 15th. So we said, well, we'll take September 15th. It turns out, though, if you look up there in the top left, we also have an event today in Spokane. So half of our team is there and half of our team is here. And I won't bore you with all the other stuff that we do beyond State of Reform, but thank goodness we have a big enough team to be able to do it. And we have volunteers here and a series of folks to help us pull this all together. I mentioned some of the other vehicles that we use for information distribution. We have this conference, and this is our anchor event, but we also have, as I mentioned, the website. We now are over 60,000 healthcare email addresses in 4 states, 5, but really 4. So we have our Oregon list, which I think is about 12,000 Oregon healthcare email addresses, and then we have California and Alaska and Washington. We have 1,500 in Idaho that we don't really think about very much, because Idaho really does not like to talk about healthcare, and they'll tell you if you ask them. And then, of course, we have Dear Governor, which is a book we do every couple of years. You've seen that in previous years here. We don't have copies of it today, but we will have a new version for next year, and then a job board at the site. We rely very much, as I said, on stakeholder engagement, and that starts with our convening panel. This is a group of folks that puts together really the thought leadership around the agenda, helps us kind of sort through what we ought to be talking about and how we ought to be talking about it. So the content that you see in the agenda today is a result of the conversation that these folks on our convening panel have fostered. And that happens in a room together, that happens by email, happens by phone. It's a multi-channel conversation, but we could not do this without them. So on behalf of our team, I just want to say thank you to their engagement with us. In addition to as I mentioned, the convening panel, if we don't have sponsors, we can't make this go. And Garvey Schubert Bear has been with us almost since day one. It has been with us since day one here in Oregon, 4 years now running. As one of our 2 event sponsors, we really could not do this without them. FamilyCare is the other. Jeff Heatherington, I mentioned, is going to be up on stage. And I think it's pretty cool to see a health plan or providers like Providence here in a second say, you know, we ought to talk a little more and be a little more transparent, a little more honest and candid with each other, because, you know, health plans and hospitals, and those are the organizations that have the most to lose from significant change in one perspective. And so to see that they are invested and engaged both in their time and their thought leadership and their financial resources, I think is a testament to them, and FamilyCare is at the top of that list. Providence and LifeWise, as I mentioned, they are sponsors with us across multiple venues, as are Stoll Reeves and PH Tech. So for all of our sponsors, including some of our track sponsors, can you just help me give them a round of applause real quick to say thank you? Thank you, guys. I appreciate it. It takes a village. With that, why don't we have Dave and Tammy and Jeff come on up to the stage. There's stairs right here, and we'll begin our conversation. Where do you want to sit? I'll sit down here. As I was telling the AV guys, I used to have a TV show in Puget Sound, and I'm not that vain, but I'm vain enough to know that what little hair I have left looks better when I sit this way. How are you? So I'm going to sit this way. How are you? Good to see you. And invite you all to sit on that side. Thank you, each of you, for being here. Jeff, as I intimated, we were having a pretty active conversation last night, and we'll get into some of that here shortly. But I always like to start off with this question about, you know, what are you watching in the market today? Because I think it's always interesting to know what senior leaders in healthcare are spending their mental energy thinking about, and what data points and trends they're watching. So how would you answer that question?
Well, I think one of the big things that we're watching, 2 things that we're watching, and this is, of course, in the Medicaid population. One is the continual rise of drug prices, which are going up at a tremendous rate, and particularly the generics, far greater than the trends you would expect. And the other, of course, is state financing of the Medicaid population. Mm-hmm.
You've been in the news a little bit about state financing and Medicaid population. Is Medicaid funding problem top to bottom, or is Medicaid funding really an issue as you see it at the top? You know, with the state and the feds, things are working okay at the bottom with plans and providers. How would you characterize Medicaid funding challenges?
Well, I think in Oregon, and this will cause a little bit of a stir, but the question is whether or not you have actuarially sound rates or whether you have politically set rates. And in Oregon right now, there's more politics in it than needs to be.
Yeah. You've been pretty vocal about that. I want to maybe jump into one of the comments that you said last night, because Dave had an opinion on this too, and I'll ask you, Dave, to follow up. But you had made a comment about how this time in the state of Oregon and Medicaid at the OHA is different from previous times during your career at the OHA. How would you characterize the OHA these days?
Without getting in trouble, I don't know that I could. But I think that right now we have, frankly, a need for transparency. They are probably the most hidden agency in terms of the way they work. They do not reveal what they're doing. And you know, one of the reasons why we have a lawsuit is because we can't see behind the curtain. And this is the first time this has happened in 2015. You just can't see what they're doing. And I think if we did get behind the curtain and saw what they're doing, there would probably be some real stirs.
So Dave, I want to ask you a question about that OHA, but first I'll ask you the question I started with, which is what are the things that you're watching as Providence, Oregon, or the regional CEO of Providence here in Oregon? What are the trends and data points you're keeping your eye on?
So just, I think Jeff hit on a couple, but I would say this is a very interesting time for the delivery side of healthcare, moving from and balancing kind of what's been fee-for-service episodic care into more managed care, population health. And I will say living in the middle of both is a very interesting place and presents quite a few challenges, but also opportunities for us to look at how we do things differently and how you engage providers and our caregivers and so on, and really delivering care in a different way, but also understanding that the revenues and things are still flow through some traditional mechanisms as we move to the new ones, and how we engage with payers and others in recognizing that work. I would say, you know, CMS kind of uses blunt instruments. You know, we still don't see good necessarily outcome measures. It's still very much process measures. And in Oregon, we tend to be penalized for being good performers by policy. And we're all high achievers. We want to do really well. And the reward for that certainly from CMS, and I think this may be a little bit from our own state in the Medicaid program because they link, but is how do you recognize when you're doing a really good job and make sure that both from a clinical side and economic side that we're seeing the benefits flow to the organizations that are making that happen. So I would say, just to add on to what Jeff said, I think that's a challenge. The other one, and it's a little different, but is, you know, what are we doing around making sure that we have the right workforce and so on for the future? I think what we're starting to see, and I know many organizations, we're starting to see a lot of folks towards the end of career, and how do we attract new people? How do we, attract and have the right kind of talent to move forward? And I think it's a looming issue in the physician side, in the APP side, nursing. You kind of go through the professions, and I think we've got a looming crisis, and I think we need to find a way to bring and get people excited to be in healthcare. We have jobs, we will continue to have those, but I think we have a potential we're not going to have the kind of workforce we need to have.
That workforce development point is a great segue to you, Tammy, but I want to come back to this OHA question, Dave, and get your comments maybe on Jeff's response, but also your general response to the question of how is the OHA these days to work with compared to other periods of time during your career?
Well, and again, we work closely with Lynn. I mean, I think she's trying to look at the OHA and how it's organized and structured. I think it's really important that there be clarity around what we're trying to achieve, especially through the CCOs and the other work that the OHA, and they have a continuum of areas, including mental health, by the way, which I think is a whole nother issue that we need to really get on the table. But I think back to the transparency, what are we trying to achieve? What are the metrics around that? What do we expect from the CCOs and so on around delivering on what we've set into place? How we support that, and try not to do things that take away from the direction we're going, but are in support of. And it's not always clear that that's the case. And I think we need to hold Lynn and her team to that partnership around how we continue to move forward in the work that we're doing. And it's a critical time. We've got this next biennium, we've got some really significant budget issues. If we're not building on the strengths of what we're developing now and transforming and moving those things forward, it's going to be a real mess. So I think that engagement and that continual working about what's working, what isn't, and making sure we stay focused on on achieving success will be
So
important.
let me just ask a follow-up to that and see how you'd answer. I think all things start at the top when it comes to culture and organizations, and Lynn has a boss in the form of Governor Brown. Mm-hmm. How much of this would you characterize as specific to Governor Brown and Lynn Saxton, or how much of the challenges at OHA that you're both speaking to, how many of those challenges are a function of some disarray which has been at the helm in Oregon leadership, particularly healthcare leadership in the last 18 months? How much do you ascribe to the current leadership, and how much is a function of the context in which they're operating?
Well, I think it's both. I mean, you can't go through the kind of change and disarray that went on with OHA without taking the time to create stability back into the system. That just is a reality. Yeah. And I think, that's Lynn's job. I mean, I think she's working on it, but, she's, jumped on a train that's moving fast and's got to restructure and reorganize OHA. And not to be critical of the previous leadership, I think they helped us to get to where we need to be, but, she's got to do that and modify the culture and do the things to keep us moving forward. I think Governor Brown's been very supportive of the work that's going on, and I think engaged with it. I think her bringing Jeremy on as the healthcare policy advisor is a great move. I think he's very knowledgeable, and that's going to help us. We have to be patient a little bit with the changes that are going on. On the other hand, I'd like to see a lot more engagement of the provider community, the CCOs, and many others in that process. Yeah, great. Tammy, thank you for joining us. We'll start with the easy question first, as I gave these two gentlemen. What are the kinds of data points and trends that you're keeping your eyes on? I say that because the tougher questions follow this one for you, Tammy. But what are the trends and data points that you're keeping your eye on as you think about the healthcare marketplace in Oregon?
Well, thank you. I'm really honored to be here among all the presidents, CEOs, and I'm just a dean of a college of public health, a school of public health. We're the first being accredited, so we feel very honored and also with a sense of responsibility. The way we feel and the way I look at my eyes, watching for the system is more than just a health delivery system. I kind of chat with Dave before. It really is about the entire health system. That is more than just a delivery part of it, public health system, and all the social determinants that allow us to support a healthy population. So I really keep my eyes on all of them. And I know I'm not in the trenches to do every day's work, but you know what, Dave is right. And I have my eyes on the short term, medium term, and long term view. So when I look at the short term is that Oregon, we know, is the leader and very innovative place for healthcare system transformation. Well, that is an opportunity. It's a challenge for all of you to deal with the changes. But at the same time, this transitional period is great for a university, for School of Public Health. Why? We are the research and education partner for all of you. So we like to use this, transition period in short term. We ask our faculty, our staff, take this opportunity to do the research that we needed to find out what works, what doesn't work. It's not all about publication, but it is important to let people know so we can learn from the best practices and allow us to see what is improved and let other people know. That's the short term itself. We like our students to become next generation of the workers. So we like them to do the internship now, understand the real world problem. Yeah. So those are the things is short term for me. Medium term is we know that, just like you said, more than just a healthcare system, we're getting older. I should say we're getting more amazing, not older. I read that way. Didn't want to call myself getting older and older. I'm getting more amazing. So we know more, but we need a next generation. So the next generation, more than just the professional. So we need immediate training of existing professional workforce, as well as the future leaders, workforce for the leaders. So how do we make our curriculum relevant? And it's very important because it's not those textbooks ready lecture anymore. We need you. Many of you have actually been guest lecturers in our students' classroom as well as in internship. So we develop many curriculum, professional courses for the medium term to see what's needed. The long term, let me just say one more thing, is that we know all of you is in the trenches, but all of us really want to have this health care or health and well-being for all, for every person, every family, every community, and that site for more than just for the kids or for us, for rich, for poor, is the lifelong health and well-being really is the vision for all of us. To do that doesn't mean that just is things we can say. We really need to begin to think in a realistic way. How do we use this upstream preventive? I know it's hard because it is not like you can cure disease and find a miracle drug or procedure to do immediate things. But we have many things, I call them a precision health method, to help all of us to keep healthy. So our life is not how long we can live, but how long we can be healthy. So those concepts is long term. And then as research and education partners for all of you, I think that's my eyes on all aspects of that. Does that make sense?
That's great.
Yeah.
Jeff, I know you've been involved in higher education, workforce development issues, helping to launch a school yourself. To Tammy, but to the audience in general, what is the workforce lacking today that you would like to see more thoroughly developed? When you're trying to recruit great talent to FamilyCare, what are you seeing that's sometimes missing that you'd like to see more of?
Well, I think the basic missing in the healthcare system is the lack of primary care providers. And if there's anything, and I've been saying this only for 35 years, and obviously no one's listening, because we have seen a decrease in the number of primary care providers. And the bottom line is that every other industrialized country in the world has probably 3 to 5 to even 7 times more primary care providers per their workforce than the U.S. does. And there's a direct correlation between primary care and the cost of medicine. And people in the U.S., we do not understand it. We do not finance primary care. We underpay it. We overcharge it for education. And as a result, our real primary care workforce is down to about 12%. Where if you look at most of the other industrialized countries, their primary care workforce is up around 50 to 60%. And if we don't change that, we don't even have a chance of getting at the costs.
So you have been pretty vocal about some hospitals having charges that are not appropriate, and there has been I'm leading obviously into a follow-up question with Dave, but there have been studies out that show that pricing is about 75% based on market leverage and 25% based on cost. When all of the money goes into health plans or into hospitals, makes it an awfully difficult incentive to recruit into primary care. But how does FamilyCare try to keep collaborative relationships with hospitals and at the same time try to drive down pressure in the market pressure in the face of increasing consolidation?
Well, having good relationships with hospitals, frankly, I don't think it's been a big problem for us with most of the hospital systems. Obviously, there's some tension between any payer and the hospitals. I think the biggest problem that you have in terms of holding costs down in the hospital systems is they really are the only game in town. And so to some extent they can charge anything they want. That's not gratis, and they don't get away with being able to do that, and I don't think necessarily they try to get away with it. But the bottom line is that I think we need some consolidation with regard to services. Not everybody needs a gamma ray knife. Not everybody needs a heart cath lab and so on. And I think eventually we'll have to see that the duplication of services in hospitals has got to go away. The problem with that is that then you create even a more powerful negotiator on one side for what the prices are. I actually don't know how you get to that.
When you have hyper-consolidation of one negotiating side or the other or both, it tends to deliver a regulatory response that may be down the road here, but this is certainly a heavily regulated industry.
I would say that my biggest concern within working with hospitals is the employment of physicians. And my concern about the employment of physicians in hospital systems is that the physicians then become less of caregivers and more just production assistants. Some of the hospitals that I've heard of, not only in Oregon, but around the country, you take your primary care doctors and you say, you got to see 6 patients an hour. Is that good care? Or is that just a revenue generator? Yeah. And I have a personal opinion. I think if you're going to do a good job as a primary care doc, maybe 3 patients an hour is about right. Now, that's one person's opinion, but how do you sit down and actually listen to a patient, understand what they're saying, and then give them the advice and counsel that they need to go forward if you're limited to 10 minutes?
So, Dave, there are, I think, 3 C's that I hear in Jeff's comments here, or that are implied in this discussion, which is cost, culture, and consolidation. And I said last night—
That was pretty good on my part, I want to say.
It's a fantastic job.
Jeff was so articulate.
And, as I said last night, and I'm happy to say, and I say anywhere, I think that Providence is top of class in terms of how it is engaging the healthcare marketplace. And you addressed this in your opening comments, that you're spending a significant amount of your time on this question about population health, not heads and beds, right? And which might be the hospital perspective of 10 or 25 years ago, and it's not Providence's perspective today. So thinking from the view of a hospital system that has direct payer contracts with employers like Boeing, that has a health plan and a risk model, how do you keep costs low so you can be responsive to providers, where at the same time the hospital culture is the hospital culture, and teaching everybody at a hospital how to be a population health centered culture is it's a challenge. Sure. How from the view of a payer do you address these questions that Jeff is speaking to?
Sure. A lot of questions there. And of course, now we fully disagree on most everything because we employ doctors and we're hospitals and, But I would say one of the benefits of having a full continuum with a health plan is that, and those of you that know Jack Friedman, he was 3 doors down from me. So we would have great discussion every day around how are we delivering on what the needs are of the people we serve. If it's too much, why is it too much? Are we doing the right thing or not the right thing? How are we getting the right information so that we know whether we're doing the right thing or not the right thing? And being able to actually engage in that dialogue every day around the expectation of delivering on high quality care when we interact with patients, but also to make sure we're doing the right thing to folks at the right time in the right place and making that affordable. And that's the right discussion. You should be having that all the time. And there's unit cost. And by the way, we all read the article, The Bitter Pill, and I tried to explain pricing in healthcare, and after about 2 minutes, people glaze over. There's no rationale to to, you know, a charge master, and if anybody tries to explain it to you, don't let them do it. Yeah. It's an artifact of many years of how providers were paid, how hospitals were paid. So really it's fundamentally about looking at cost structure, looking at how we deliver, and looking at total cost of care. And if we're not focused on total cost of care and the inputs that go into it, utilization and the unit cost, then we're not focusing on the right thing. That said, healthcare is expensive. I mean, delivering acute care is expensive. And by the way, when I have acute care needs, I want the best nurses, I want the best physicians, I want the best, whatever it is, I want that, and I want it 24 hours, you know, a day, 7 days a week. It needs to be the right thing. So, you know, how we do that efficiently and effectively, I think one area, and a lot of us are focusing on this, is high reliability. Are we delivering safe care at the right time for everybody? And I would say there's a lot of opportunity for us to be better and be more highly reliable so that folks can trust the care they're getting. That will improve cost, but it improves outcomes and it's better for the patient. So I think in this world of today where, you know, cost is an issue. Healthcare is expensive and people are paying more out of pocket for that. So I would say total cost of care, I think the system's got to evolve and understand. Employing physicians, by the way, it's an interesting learning curve, and we've been on it for a while. And I think we're at a better place now where how do you actively engage those physicians that are employed in understanding that they have control over the work environment that they work in. And that's the place you've got to find in an organization. They're highly trained professionals with high skills, high abilities, and high motivation to do the right thing. And you've got to get the right leadership that can support that and live with the notion of that not everything's the same for everybody. And we've got the leadership team in place that's looking and finding the way to make that happen. Because you've got to have ownership, right? All of us want ownership in the work that we do every day. I want the environmental services worker owning the job they do, that their work creates a safe and sterile environment for the patient. Physicians who are managing a population as well as the individuals, knowing every day they have the influence over what happens. The team-based model. I mean, I've shadowed with PRRs and MAs. They care deeply about the patient panels that they serve and the patients they serve and own how that works in support of the physician and the nurse practitioner. You've got to have all those things in place. And that's what I mean, moving from where we've been into a place where you value that, and then you can go to the payer and say, here's what we're delivering on. And we want to be paid different for that than just a traditional piecemeal way that you've been paying. That's been hard. I think most payers are struggling with getting the right information from delivery systems and being able to interact in that way. Now, we do it with a health plan because we have it. It's part of our system. And we're able to do it. Our health plan funds investment in patient-centered medical homes because they see the benefit of that. So there's a lot here.
Yeah, no, I think that's a good answer.
I get excited when I hear Dave's talking about this kind of holistic system.
Yeah.
The reason is that I see our students, I see what we can do as education and research partner for that. Because the ultimate goal, the change, we're not there yet. It's struggle all the way from here to the first changes and the second changes. Each stage of the changes that we have, I keep my eye on it because I can see it's more than you need a primary doctor. I mean, I have nothing against doctors. My kids are doctors, so I'm fine. My long-term care actually is taken care of by both of them. So I don't have any problem with that. But I think you require a team. That team, we already said for CCOs, that you need more than just the doctor, although the primary doctor probably in charge. But the thing is, how do you keep the primary prevention as well as the secondary prevention that will actually cut down the cost with people like community health worker, like people can help you to eat right, to, have to say that in the factors that are contributed to our health, only 10% are medical care.
Yeah.
It's 90% has something, about 40% is our biology genetics, the social the environment, but mostly it's lifestyle. So our eat right, exercise, you know, we can talk all we want and not smoking, but people not hearing. We got to think smarter. The health promotion, change behavior has to be part of it. And that part of it is not, you know, keep telling me, no, 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 you can't do that. There's a lot, actually we know plenty of social psychology behavior, positive for youth. We can use those kind of things to encourage people to live right and be healthy. So really exciting for that part.
I want to ask a question related to the triple aim of you, Tammy, and then go to Dave and Jeff. But different from the triple aim is the paradigm of 3 of cost, quality, and access. And if you, I mean, I know that we all have to focus on all 3, and of course, I know that when we focus on everything, we focus on nothing. To these gentlemen, to the health system, which of those 3, cost, quality, and access, would you say the health system or the hospital system or a health plan system should focus on? Because as you said, you're not in the trenches, but you are thinking about big picture, long-term, short-term. Which of those 3 do you think is most important for the marketplace to be thinking about now, cost, quality, or access? And I know the answer is all 3, but if you could give me one, I'd like to hear your thoughts there.
I would say improve the population health. It's so upstream. It's hard. But you know, this group are smart. And at the end of the day, if you're going to change a system, you're going to do the transformation. Often, and I personally experienced many times when the great idea come along, you know that's the right thing to do. You know you can go upstream. The end of the day, often people say, oh, over my dead body, there's never going to happen. You know what? It happens. You don't want to be the last person to say, gee, I wish I was in the, with everybody. Think smart and innovative is the way to go. But to me, is improve the population health. And I'm talking about health system, not just health care system itself. Well, but got it to the health system overall.
And you are echoing something Dave is saying, and Jeff, I'll ask you about it, or segue to you, which is if you want to take care of population health, if you want to move upstream, that requires much closer integration and collaboration, and maybe consolidation within the healthcare system. The more you consolidate, the less focused you are on community. I want to ask you about the triple aim because I know you have an opinion on that, but I'm interested in this sort of paradox that I think that we have about community-centered care and healthcare being local, but this need to be upstream and to manage population health and the ACA construct, which all of which is driving more consolidation. Do you see that paradox there, or do you see it differently?
Well, I'm not going to answer your question the way you asked it. I'm going to.
You're not the first.
I'm going to take it around to your first question. First of all, as I said last night, I think the triple aim is a deficient model, and it sends us off in the wrong direction.
I think you were less diplomatic last night.
I was, yes. I think it's nonsense because I think the thing that we leave out is exactly what Tammy's talking about. Health care, the healthcare system, is at the tail end of everything we should be doing in health. We need to develop healthy communities, and that involves the healthcare system at about the 10% level. The education system, the level of economic health is important, our environment is important. All of these things are what create either a healthy community or an unhealthy community. We don't pay any attention to that, and we talk about cost, quality, and access, which is at the back end. And so this is where I'm with Tammy. There's another factor in there, and that's the demand that we create with the way we live, with the way we organize our communities, with the way we pay people, with the way we take care of our children, both in education and in early childhood development. And I think that's the first conversation we should be having in healthcare, rather than how do we control costs. because if we create a whole generation or 2 or 3 or 4 of unhealthy people, you don't have any control of any of those other factors.
I want to come back to this, but I want to just highlight for a second one thing that maybe not many of you know, which is we don't give them any questions in advance. And we don't say, you have opening 5 minutes to take wherever you want. We tell them specifically, you are getting thrown to the wolves and you better just love it. And because we think that sort of authentic response is much more valuable for our overall discussion. And so I just want to say that and say thank you for your willingness to engage in these questions. And a little secret, I ask sometimes 2 or 3 questions each time I ask a question. So you can take one or you can take another, and it gives you sort of a safety valve. But I knew you had an opinion on the triple aim, so I'm glad you got to that. How do you do that, though, what you're talking about, which is integrate more upstream, things like nutrition, schools, childcare, social services, housing? How do you do that without creating one big public utility that takes care of all health? I mean, it seems like you have said in previous times, Jeff, that we need to think big and we need to move beyond incrementalism. But building the kind of trust it takes to do all of that work you're taking requires either incrementalism or a sweeping law that I think puts us in the courts for a generation. So how do you move that direction and foster trust?
I think it takes even more than that. First of all, it's going to take resources. And part of the problem is that the healthcare system is taking about 50% more than it needs to be taking out of the general, what I would call the general welfare fund. We're at 18% of the GDP right now. We should be at about 11. If we had that kind of money, we could put it into schools. We could put it into infrastructure like good water and good sewers and so on. We could help reduce some of the housing problems out there. So I think that's one of the discussions we need to have. The other part of the discussion, I think the healthcare community needs to be more outward focused than inward focused. Mm-hmm. You know, we're always talking about ourselves. We're not really leading the conversation that Tammy's asking for about, where's the healthcare community talking about education? Is the healthcare community out there helping, schools get funded? Are they out there helping early childhood learning things get funded? Are they talking about it? And the answer is right now is no. Mm-hmm. And we really ought to be more focused that direction and looking at our costs and how we can invest there to keep people out of our system.
So Dave, what are your thoughts on that?
We
ought to be looking externally.
Yeah, I agree. I mean, I think this, and Tammy, I appreciate it, and Jeff, I think we have a great opportunity now to look at the bigger picture. I mean, the rubric of population health, and it's beyond managed care. It's really about population health. It's about the things you're talking about, and how do we participate in that dialogue and in the delivery models that change that. And if we're not, shame on us. We absolutely should be at those tables, not driving them, but being a participant and understanding of the role we play. And I actually think there's a great opportunity right now with the changes that have happened around fewer people who need charity care because of the Affordable Care Act and expansion in Medicaid and so on. I think health systems are at a place where they can invest in broader opportunities in our communities. I mean, we've studied it. We know that if you have stable housing, you have better health. I mean, duh. But I mean, we've actually demonstrated that that's the case. We know early childhood education. By the way, we know if you're born with normal birth weight, you have a better chance of succeeding in life than if not. So how are we working with Medicaid, where 50% of our deliveries are in Medicaid, to support prenatal care so that you have the best opportunity to have a normal birth? Now, there's a whole lot of issues that I think we have a chance in this state to look at around poverty reduction, and I believe the current governor is engaged in that process. I know we've met with lots of folks to talk about this. You know, we have business communities interested in it, and there's two parts to that. One is we got to create jobs. Creating jobs is really important, and we need to be careful that we don't create policies that disincent us creating jobs in this state. Two, there's a lot of policy issues around how different programs work that create cliffs and all that kind of stuff. We've got to smooth those out so we incent people to continue to work and then support them, childcare, et cetera, et cetera. You can get into all these things. That's population health. We need to understand food deserts and where there's issues and how are we supporting those. All that's really important. But, and this is where Jeff and I disagree, we still got to deliver on a AAA model when we get around to delivering health care. And you can't do one part more than the other. You got to make it affordable across the whole thing, and you got to deliver outcomes and things that help around the health equation. So anyway, this is a critical time, and we can step up and do this well. Hard work, rethinking, reinvesting in a different way. Maybe it has some impact in healthcare, but if we actually can move people out of coming into hospitals, that's a lot of money.
Let me ask you a follow-up.
I'd like to make one correction. It's not that I don't like the AAA. I said it was deficient, and it's deficient because it doesn't add in the demand there. I think the AAA parts are important, but we're leaving out a huge piece when we focus on that.
Let me ask a quick, just sort of a side follow-up based on the conversation last evening. BJ Kavner asked about whether we should move, in order to address those issues like childcare, housing, social services, whether Oregon should move to a $15 minimum wage to help support and offset a trap of low-income poverty and working poor. What do you, is that a blunt instrument, or do you think that that's the kind of thing that actually would move the ball forward on some of those issues? I mean, I ask that because
you don't shy away from the hard questions. I mean, I don't know if 15 is the right number or not. I think paying a fair wage is important. Different studies have been done about where that ought to land. John Tapania has done some interesting study, you know, John from Echo Northwest, not Echo Northwest, but anyways, he's done some good studies as an economist about where are the right places to put minimum wage. I do think, though, the notion of paying fairly for work is important, and having enough income that allows you to live in our communities, you know, have access to the thing, you know, housing and those kind of things is important. Yeah. So I don't know what the right number is. It's probably not where we're at today, but I think we need to take a good hard look at it, but not just as the answer. There are many other things around that need to be done at the same time.
Yeah. So Tammy, I want to start with you and give everyone a last chance.
Can I follow up on one thing?
Let me ask the question, then you can take it wherever you want to go.
Okay. So I don't have to answer the question. I can take it anywhere. Go ahead.
I want your thoughts on what this audience is, sort of the last question I'll pose to each of you. What this audience ought to be thinking about as they go out and they live on the front lines and in the trenches. What advice would you give this audience of policymakers and healthcare executives as they are engaging in trying to improve the healthcare system? That's a question. You can take it wherever you'd like.
Okay, I will. But I want to kind of follow up in some way of what Dave has said, and probably the combination of the two. Just thinking about all the audience in the audience who are old enough or amazing enough that remember the computer still in mainframe. So you have to go to a big place, give the cards, and then figure out what's going on. And now, in our lifetime, I mean, I'm not allowed to get my cell phone here, but all of us have a cell phone. And then you think about even more, many of us have Fitbits, or if you get paid more, you get an iWatch, you know, Fitbit is cheaper. But the reason is what you're thinking about, we're thinking about, there's two extremes in some way. That is, we don't want to always go to the hospital, to go to mainframe to take care of our health. So the world changed. They changed in such a way without us knowing it, and then it become. I think health system or healthcare system has to do that transformation, has to change. How do we get there? Take all of us. We take a government, take the healthcare delivery system, the organization, the industry, and the education, for us, higher education. We need to keep our eyes on your need. And we talk about, I don't care if it's a triple aim or is whatever the system you think is incentive for us to move forward. Sometimes we do make a mistake. And that's where we need to learn from this innovative aspect of it. So for me, when you're in the trenches, you always want to think about, like Dave said, patient. Even the patient is one way, as they are the one, is your population that you need to take care of. For me, it's all of us. So it's really take a little bit different way of looking things. Silo is never good. Integration is much better. So that's really I don't know what I answer your question or not, but that was my answer.
So let me ask you just one quick follow-up. We're short on time, so yes, no, maybe, or no comment. I'll ask you the same question I asked Dave. Should there be a $15 minimum wage to help create health in Oregon?
As for me?
Yeah.
I think we should pay enough, but I don't know, minimum wage is $15 or less or more. I can tell you all the student worker in my office, they are not quite there yet, so I have to look in. But they're student, they're just transition period, yeah.
Dave, what advice would you give to the audience of healthcare executives and policy leaders to take with them as they go out and try to improve the system?
First of all, Oregon's a great innovative state, and look around and folks here. I mean, we're doing some incredible things. I think the time we're in now is one of great opportunity. It's not for the faint of heart, but it's a great opportunity for us to rethink, redesign, transform, whatever language you want to use, how we do what we do. Putting the consumer, who's going to be more educated, more knowledgeable. I use consumer because it's not just a patient or a member, but it's people making a decision around their health, not just healthcare. The innovation going on in the technology side is incredible. It's going to shake itself out. There's going to be things, back to your point, that we have no idea what could be the potential for us to monitor and track and do the kind of things around healthcare and health of individuals. I think the research realm, when you look at what's going on, just even in Oregon with the Knight Cancer Institute, work we're doing in immunotherapy, that over time, we're going to see cancer being treated differently, maybe even prevented, maybe in our lifetime. That's going on right here. And how do we support that work? Workforce development, you sort of go through these things. We have great opportunity if we take advantage of what we've done over the years and rethink and reposition and really affect the health of our communities. And that's what's exciting. And I think whatever we do, how we think about what we do, how we position our organizations, reposition our organizations, is going to be really critical. And it's right now. It's what we do today.
Yeah, great. Jeff, same question. What should people in the audience be thinking about on the policy side or market side as they are trying to improve the system?
Well, I'd probably two or three things. The first is, and I'm going to underscore what Dave says, I don't think the people in Oregon really understand how good a system we have created here in Oregon. We have a really good delivery system. The Oregon Health Plan is really a top-notch model for how healthcare should be delivered. We have community organizations who have organized around setting up a healthcare system. We have, with the prioritized list, the best evidence-based benefit list in the country, and we don't advertise it. We have better access, and access is different than coverage. We have, all of our people on Medicaid have direct contact with a primary care provider. So I think we have to tout what we have, because, and congratulate ourselves and sell it to the rest of the world, because frankly, we're doing a better job with our population than a lot of states are around the country, and that's one. The other thing I think is we have to avoid thinking that there are silver bullets out there. There are no silver bullets. Technology is not a silver bullet. Coverage is not a silver bullet. The magic, the minimum wage. You have to think of the whole. Yes. And if we keep our eye on the whole and answer all the questions and not get diverted over to here, then I think we'll have a better chance of defining what values we really want to concentrate on and what kind of a population and how we're going to help the entire population get healthier. And I think the last thing is we've used the term patient and enrolled and all those kinds of things. We're really talking about people. And if we don't keep in mind that it's every single person that we're trying to help, not just the ones that are coming in our doors, but the ones that we don't see, the kids that we don't see, who have all sorts of needs that the community needs to address, not just a healthcare system. If we don't keep our eye on that person and all of the people here, then we're going to miss the big picture.
Great comment. I got to ask the last question about $15. Should Oregon have a $15 minimum wage?
I have no clue.
Such a diplomat.
Yeah.
Thank you all. Let's give them a round of applause. Thank you guys.